first ones were for the lung. In patients with pulmonary sarcoidosis, should glucocorticoid treatment be used versus no immunosuppressive treatment? In patients with pulmonary sarcoidosis, should one add immunosuppressive treatment or remain on glucocorticoid treatment alone? And then 2 picos for skin. In patients with cutaneous sarcoidosis, should glucocorticoid treatment be used versus no immunosuppressive treatment? And in patients with cutaneous sarcoidosis, should one add other immunosuppressive treatment when treatment with glucocorticosteroids has not been effective? And then you have other PICO for the heart, for cardiac sarcoidosis, for neurosarcoidosis, for fatigue, and small fiber neuropathy. Here you have the first page of the paper, which is accessible online. In conclusion, the ERS task force for treatment of sarcoidosis began in April 2017. Final approval of the task force recommendation was made in April 2021. The task force developed great recommendations and comments regarding various aspects of sarcoidosis. Thank you. And now it's Bob.
Dominic. My task is to summarize some of the statements that have been made as a result of what Dominic has nicely described as the process that we went forward with. I think it's important to realize that this was an attempt to add scientific rigor to what has been an area that does have a lot of issues. Now, I do have some disclosures that are on this slide. There are various pharmaceutical companies that I've worked with. But I want to focus now, and none of that really had any impact on what the decisions that we've made. So PICOs 1 and 2, this is a summary again that we looked at either corticosteroids or immunosuppressive for pulmonary disease. So if you think about treatment for sarcoidosis, we're going to talk mostly about anti-inflammatory therapy. And the first line of therapy being corticosteroids, that was a separate PICO from non-corticosteroid therapy, including the non-biologics such as methotrexate and azathioprine, and for the biologics such as infliximab, rituximab, and repository corticosteroid injection. So for PICO 1, which was Athol Wells and Paulo Rotoli, in patients with pulmonary sarcoidosis, should glucocorticoid treatment be used versus no immunosuppressive therapy? So this is the process. PRISMA is a way of looking at identifying which articles should be used. It's a very formalized protocol, and the methodologist assigned, in this case Alexandra, went through all the different articles. The advisors on the committee, the clinicians also identified these articles. And then we came up with a total of 19 articles that were qualitatively analyzed. So we started with, you can see almost 2,000 articles, over 2,000 articles, and got down to this 19. This is just for use of corticosteroids in pulmonary sarcoidosis. Now, there was a general concept that had been evolved over the last few years about treatment for patients with sarcoidosis, and it really goes along the line of the fact that there are 2 reasons to treat. One is danger, fear of death or significant morbidity, versus improvement in quality of life. And these actually have separate measures. If you ask patients, and one of the things that we did during the outcomes that we were looking at in this task force, it became clear we didn't know what really outcomes the patients felt were important. So the European Lung Foundation helped us by doing this survey of 1,800 sarcoidosis patients, and subsequently published. And you can see that the most important information to the patient was quality of life, and imaging wasn't that important to them, but really they could care less about pulmonary function test results. Sorry for pulmonologists that realize that patients really want to know how they feel. It's interesting that mortality and adverse events were not as important to the patients as their overall quality of life. But mortality is still something that we as clinicians get worried about, and especially for patients potentially getting worse. In the last few years, several papers have come out from different centers across the world looking at mortality predictors. This is Athol Wells' group in Great Britain, this is Dominique's group in France, and this is our group in the United States. And you can look at the presence of fibrosis, severe, moderately into severe obstruction and restriction, patients with evidence for pulmonary hypertension. And this Walsh composite score looks at both pulmonary hypertension, pulmonary fibrosis, and severe restrictive disease. And you can see that these all identified an increased risk for death at 4 to 5 times higher than those who do not have these factors. So we do have a way of identifying patients at risk for more severe disease. So this led to the first PICO, the answer to the first PICO. In patients with pulmonary sarcoidosis, should corticosteroid be used versus no therapy at all? And the focus of the PICO was to look at patients who had major involvement from pulmonary sarcoidosis who were felt to be at higher risk for future mortality or permanent disability. So we felt that there was enough information from the literature to make a strong recommendation in this group, because the group felt that patients with significant pulmonary disease at risk for mortality or permanent disability should be treated with glucocorticosteroids as the first line of treatment to improve or preserve pulmonary vital capacity and quality of life. So the second PICO then looked at patients who were on corticosteroids, and the question was, should one add immunosuppressive or remain on glucocorticosteroids alone? And this PICO was addressed by Dominique Belair and Elise Lauer, and they again looked at using the PRISM. They went and identified a group of studies, a total of 1,300 studies that have been reported in this area, but they only really came up with 6 studies that were really well identified and could be used to answer these PICOs. And what they came up with 2 recommendations that met the grade criteria. For symptomatic pulmonary disease, patients at higher risk for morbidity and mortality, the same we just gave us the criteria for patients treated with steroids, and if they had unacceptable side effects not from glucocorticosteroids or had worsening disease, the methotrexate could be considered as a conditional recommendation. Now, a strong recommendation is something we would recommend for most patients. A conditional recommendation is something that the clinician can consider, and it's something if they want to use a different agent, that is okay. But this is a recommendation of the committee. In the same way, the recommendations of the PICO for patients who are on immunotherapy with glucocorticosteroids, with an immunosuppressive agent, and continue to have disease, the addition of infliximab was another conditional recommendation. And the quality of evidence here was still low, but it was probably one of the stronger recommendations based on evidence that we had. Now, these are grade recommendations. These are very specific criteria that have been developed over the years and across multiple different areas, not only in pulmonary disease, but in other aspects of disease. So the grade recommendation is fairly formal. But we also felt that there had to be other treatments that have been used, and we had to make comments regarding this. And so the committee looked at these comments about treatment, and they made general treatment options, and then a case by case, something beyond that, where in an individual case, you may want to still consider other options. These recommendations and comments were all endorsed by the members of the committee. It went through a process of repeated voting so that we came up with a final algorithm, which I'm showing on this slide. So for pulmonary sarcoidosis, patients at low risk, that is no significant risk for impairment of their quality of life or mortality, then observation. Those that have high risk for mortality, as we just went through, glucocorticosteroids, that's a blue marker, that's a high risk, strong recommendation. And then we go to methotrexate, which is a conditional recommendation, very low evidence, or infliximab, conditional recommendation, low evidence. better evidence, but these are similar weighted recommendations. Other drugs that you can see on here that some of you may be using, azathioprine, leflunomide, mycophenolate, these are comments that people have in the committee felt are reasonable alternatives, but not sufficient evidence to make them a strong recommendation. And rituximab, JAK2 inhibitors, and repository corticosteroid injections, these are recommendations that really should be made on a case-by-case basis for patients who have failed other recommendations on this algorithm. So what about recommendations beyond the lung? And there were 6 additional PICOs as introduced by Dominic. These included extrapulmonary disease, cardiac disease, neurologic disease, fatigue, and small fiber neuropathy. And for extrapulmonary disease, we looked at both corticosteroids and for non-steroidal therapy, just like we did for pulmonary disease. When we went into this, we looked through the prism at all extrapulmonary disease, since sarcoid is a multi-organ disease. And we looked at specifically cardiac and neurologic, and they had their own PICOs. But for other organ involvement, we looked at skin, eye, liver, and renal initially, but were unable to find sufficient information for any of these other organ involvement except for under skin. Now, if we look at sarcoidosis, I've talked about morbidity and mortality, morbidity being impairment in quality of life, and mortality truly being an endpoint you want to avoid. And there are some organ involvements that we've already mentioned, pulmonary, cardiac, and neurologic. These have significant morbidity, that skin, the liver, kidney, and the eye, but really very low mortality. And unfortunately, there is very little data for these 3 groups at this time to make any specific comments. Whereas skin, there is significant morbidity that is cosmetically important skin lesions, whereas there's no mortality from cutaneous involvement alone. So cardiac involvement, there were a couple strong recommendations. The International Heart Rhythm Society had already made a strong recommendation for patients with cardiac arrhythmias be considered for a pacemaker and defibrillator, and we included that in our algorithm to remind people that that should be considered as a strong recommendation. For patients with clinically relevant cardiac sarcoidosis, that is symptomatic disease, then glucocorticosteroid was again a strong recommendation, although the information was fairly low. If the patients could also be considered for immunosuppressive therapy, either in addition to or as a replacement for corticosteroids. So some people in the committee use these as an additional upfront therapy. Others recommended using it only if you saw glucocorticoid toxicity. If you had good clinical response, then you could stop. But if you didn't, then you can consider other therapies, including infliximab, and even cyclophosphamide has been reported. How about neurosarcoidosis? Now, in neurosarcoidosis, glucocorticosteroids remain still the first treatment, and if patients tolerate this and have no significant side effects, a strong recommendation is to stay with that. However, if those patients continue to have disease, they consider alternative therapies. Methotrexate and infliximab actually have enough evidence to support them as conditional recommendations, or these other ones were just comments from the committee. Again, the comments may be similar effectiveness, but the evidence to support the recommendations was based on the evidence in the literature. Of the other organ involvement, skin was the only one that was sufficient information, and there, again, a simple pass-through initial therapy with topical steroids, then consider systemic steroids, and patients who had side effects then consider some of these alternative. Hydroxychloroquine, the anti-malarials are commonly used, but there's really not sufficient evidence. The only one with sufficient evidence to support were methotrexate and infliximab, where there have been randomized trials for use of these drugs for skin sarcoidosis. So I think that this again shows that there's evidence to support various aspects of anti-inflammatory therapy in sarcoidosis. We finished up with two other PICOs that we felt were important in the committee. The first was sarcoid-associated fatigue. And in fact, there is actually sufficient evidence to make a conditional recommendation with very good evidence to support initially consider exercise training or inspiratory muscle training, or using neurostimulants like this armodafinil or methylphenidate. Both of these have been shown to be better than placebo treatments for patients with sarcoid-associated fatigue. In patients who failed those and which other considerations, such as low-dose corticosteroids or methotrexate. And then finally was one of the more perplexing problems for sarcoidosis is small fiber neuropathy. And I say more perplexing because at this point, we still have not identified a good comprehensive therapy. And in fact, we could make no grade recommendations. There was a feeling that for patients with mild non-disabling, you may want to just watch and wait, whereas those with severe disabling, you want to treat with active granulomatous inflammation first, and then consider other symptomatic treatments, including drugs such as Topramax, GABA analogs, and even an IVIG or TNF inhibitors to be considered. So at this point, I just want to conclude in the middle here that several studies have addressed the management of pulmonary extrapulmonary disease. We have now some evidence-based recommendations, and then we have some other comments. The next step of this webinar is for Peter Corson to help us apply how we would use these in individual cases. So I'm going to hand over the directions to Peter.
Thank you very much and welcome everybody. Thank you, Dominique and Bob, for these introductory slides and statements on the overall process. And I'm happy to present a couple of cases that we maybe use as example cases to apply these recommendations to the clinical practice. So the first patient I want to present you is a 59-year-old female patient that for the first time presented in May of 2018 to our Department of Nephrology and Rheumatology, actually, for skin sarcoidosis, which was histologically proven, but she had no other clinical symptoms. So I've prepared a couple of questions for you. We followed her up and screened her for pulmonary and other organ involvement. And what you see here is the pulmonary function testing with the forced vital capacity of 84% of normal and the diffusion capacity of single breath of 71% in this patient. We performed a computed tomography of the test, and you see in the right lung and in the left lung slight infiltrates. These were proven to be consistent with sarcoidosis and contained granulomas. So she has asymptomatic pulmonary sarcoidosis, no coughing, no dyspnea, and she really suffered only from skin sarcoidosis on her upper back. So the first question I have for you, would you treat this patient for skin sarcoidosis, yes or no? You can use the poll that you just see and make your choice. Okay, we've seen 61% yes, 39% no. Bob, do you want to take it from there and discuss?
Yeah, I think that it's important to realize that the way you've set this up here is that the patient had no clinical symptoms. And we struggle a lot in skin sarcoidosis about when to decide, not to decide. And I like the terminology that has been proposed, which is cosmetically important cutaneous lesions. So it's been pointed out that a little spot on the chin may not bother me, but may bother incredibly a young female, for example. Not to use a stereotype, but if you've got a lesion that's sitting there and you're bothered by it, then that's a cosmetically important lesion. As you presented this case with lesions on their back, which you said was not clinically important, so one will presume that this patient did not have cosmetically important lesions, and I would not treat this patient for their skin lesions.
Okay, I agree. And I remind you of the algorithm we post for sarcoidosis that we need to assess the need for treatment, as you pointed out. The first step would be topical glucocorticoids, and this patient didn't have any cosmetically important lesions that bothered her, so we decided to not treat the patient. Next question is, we followed her up in September 2020. Pulmonary function tests were again performed for vital capacity of 81% and diffusion capacity of 73%. So basically unchanged pulmonary function testing. Repeat chest CT showed similar lesions, maybe slightly progressive lesions, but again, she had no pulmonary symptoms. So my next question is, would you treat this patient for pulmonary sarcoid, yes or no? The voting is still open. Make your choices. Okay, that's almost half and half. Bob and Dominique, what's your take on this?
Well, I'll start. Dominic, you can give your opinion. We haven't discussed this before, but I think that even though this patient has a progression of their chest x-ray, they really don't meet the criteria that I think of about increased morbidity and mortality, since they don't really seem to have much fibrosis yet. You can make an argument that you're concerned that if you untreat it, it will go on to be fibrotic, but the study from the British Thoracic Society several years ago showed that patients with stage 2, stage 3 didn't necessarily get worse, and so you don't have to treat them. Dominic, what's your opinion regarding that?
I agree with you, Bob. I agree with what you said. And there is a question for the third part of the web. At the end, there is a question on this topic. What is major pulmonary involvement? So perhaps this question will be considered later.
Yeah. Okay, I show the algorithm for pulmonary sarcoid again. And I think we agree that this patient has rather low risk of progressive disease. And we decided in conclusion, in agreement with the patient, to just observe, because there were absolutely no clinical symptoms related to sarcoidosis or related to her pulmonary infiltrates. So we decided to not treat the patient for pulmonary sarcoid. I'm going to go to the next slide. And recently I saw the patient again. She presented to her ophthalmologist. She was she had an appointment for a different condition on her eyes, and he identified posterior uveitis accidentally without any clinical symptoms. You know that posterior uveitis may be asymptomatic in sarcoidosis patients. So the more difficult question is now to treat the patient or not. We measure the soluble IL-2 receptor, which has been increasing from the dates presented, May 18 to May 21, over 3 years. You may discuss if this is useful biomarker or not, but there are some data indicating that it may be useful in patients with elevations. And now my final question that we didn't address in the task force report would be, how would you treat this patient at this point? Because I think posterior uveitis is a condition that may necessitate treatment for permanent damage. So please choose your answer: ABC, glucocorticoids alone, methotrexate, subcutaneously, adalimumab, subcutaneously, where there are data for uveitis. Okay, 91% choose glucocorticoids alone, and around 10% additional immunosuppressive treatment. What's your opinion, Bob and Dominique, on this patient?
Well, I actually have strong feelings about this. We published a series of nearly 400 patients of high with eye sarcoid. And I think that they need to be, post-ERS in particular, needs to be treated with systemic therapy. And anterior can get away with drops maybe, but posterior drops are not going to get there. And their alternative is an intraocular steroid injection, which patients don't find real comfortable. However, you don't necessarily need to place them on systemic corticosteroids. You may be able to control them as you wait for methotrexate to kick in. You've made methotrexate subcutaneous. I have to say that I still believe it's oral. This is a reflection of you being a rheumatologist versus us being a pulmonologist. And so we've used oral more than that. Our experience is that methotrexate works about 60 to 70% of the time in ocular disease. And so we don't necessarily have to go to an anti-TNF agent such as adulimab up front. But there are people who like that as an alternative, and it is approved, but it's not that much different than methotrexate, which I still think is a safer drug.
Yeah, I agree with this. And in this case, the patient was treated with, I have to close this first. So, with glucocorticoids alone, and she's now being tapered, and we'll see if she's, how she's evolving, and then if she's in need for additional treatment with methotrexate would be my first choice. Orally or subcutaneously, I've posted this here because my preference in doses over 50 milligrams per week is subcutaneously because patients tolerate it a little better, but orally is equally effective in dose up to 50 milligrams. So this was the first case. I'd like to present the second case of a 46-year-old female patient. She was a soccer player and felt palpitations after a warm-up for a soccer match in November of 2019. And this has come to attention recently with these terrifying images of the European Championship currently now taking place of the Danish soccer player Eriksen, who collapsed and needed CPR during the match. And this really came into my mind, and she was admitted to the hospital immediately. She didn't collapse, luckily, but she was found to have ventricular tachycardia. And this was a cardiac MRI, which showed dilation of the left ventricle with an ejection fraction of 35% in basal to mid-ventricular akinesia and late gadolinium enhancement consistent with the diagnosis of myocarditis on the image. And myocardial biopsy was performed and showed granulomatous inflammation consistent with the diagnosis of sarcoidosis. So the first question related to this case, what are your next steps in treatment of this patient? A, glucocorticoids, B, antiarrhythmic drugs, C, placement of an ICD, D, methotrexate, or E, cyclophosphamide. Okay. So A, B, and C were the preferred choices, and I agree with those choices. Any comments on that? I'm gonna show the algorithm again if I'm able to do this here. So here it is.
Well, actually, I'm a little concerned that only 59% said they put an ICD in. This should have been 100%. The patient with VTAC and with cardiac sarcoidosis, it's pretty convincing evidence that this patients are going to do much better if they have an ICD. We published a study about 2 years ago. The Danish have had studies on it, the French, showing that ICD really is a life-saving effort. And these patients are at high risk for having a secondary event. At least 25% of the time after you put the ICD in, they're going to fire again, meaning that they would have a significant cardiac event if they didn't have their ICD in. So that's a comment. So they would get that. I think the next question, part of the question though, is anti-inflammatory therapy, which is the algorithm here. And many of you voted to just give corticosteroids alone. I'm more and more inclined to give corticosteroids plus methotrexate up front. rather than waiting to see how they have morbidity. Dominic, what's your approach now to cardiac sarcoid? You're on.
Yes, I would have treated like that. Sometimes when people is older, I begin methotrexate as well as corticosteroids so as to decrease corticosteroid sooner. But as for general cases, I will do the same, the ABC responses. But I tend, because I know that cardiac sarcoidosis is often chronic and need a treatment for a long time, but there is no evidence to do that. But often I start methotrexate soon.
We should take advantage of this, Peter, because you've given a case that has two issues that came up, some of the chat's questions. One was the PET scan versus the MRI. You have a nice example of a positive MRI. In the current definitions developed by the heart rhythm people and by the WASOG people is that a positive MRI in a patient with known sarcoidosis would be sufficient for cardiac diagnosis. However, in this patient with non-known sarcoidosis, and you didn't identify a granuloma, that's one of the issues. So that's where the myocardial biopsy is, I think, important. But you have to realize that only in 40% of patients with cardiac sarcoid is a biopsy positive. So you may miss it and they still have cardiac sarcoid.
Yeah, I agree. So I'm going to go through the case. The additional workup was really exhaustive, but she didn't have any additional disease manifestation, no pulmonary, no ophthalmic manifestation, no skin, no other condition. And the first time she attended my clinic was actually in April of 2020 with the inability to taper down steroids. She had a relapse and an additional event with the ICD for cardiac disease. And at this point, which steroid-sparing agent would you start? And that was the question I was posed. We already discussed, but you may have other choices than I did. So please choose no add-on immunosuppressive therapy, A. Methotrexate, answer B. Azathioprine, answer C. Infliximab or upfront cyclophosphamide, answer E. Please cast your vote. Okay, the great majority with 91% is choosing methotrexate, and that was at this point in time also my choice, and I agree with it. And as we discussed, many would choose methotrexate altogether with glucocorticoids at first diagnosis, and because treatment is relatively long and may need a couple of years. But azathioprine would be a reasonable choice according to the algorithm as well, but we are more familiar with methotrexate, and the patient tolerated methotrexate fairly well. So methotrexate and I think azathioprine are both reasonable choices for cardiac disease at this point in time.
You didn't talk about the dose of steroids that you gave this patient on.
I've started with 1 milligram per kilogram of body weight, and then tapered down for, she was like half a year, but she needed additional doses of glucocorticoids, but my starting dose would be 1 milligram per kilogram body weight.
And you, Bob, what dose?
Yeah, this was a source of much controversy because the Japanese had published a study showing that higher dose corticosteroids, once you got above 30 milligrams, absolute dose didn't make any difference, but had more toxicity, at least their impact on the ejection fraction. So I'm inclined nowadays for cardiac sarcoid to start at 20 or 30 milligrams rather than going that high of a dose. With the exception being neurosarcoidosis, where I give that high doses. How about you, Dominic?
I think it's a very nice question because several people ask this question, what dose to use according to organs? And we can see after our work in the task force that we lack evidence-based studies to determine the correct dose. It was shown in a retrospective British study that renal sarcoidosis could respond to 0.5 milligram kilo and not 1 milligram kilo. It was not better than one, not less efficient than 1 milligram kilo. So probably in many cases, we use the dose because we are feared of the pathology, but it's not sure that it's necessary. I don't know what is your opinion.
Well, I think there's a nice study by the Dutch who just looked at, this was pulmonary, not cardiac, though I think we can wonder a bit. And they showed that the higher the dose, once you got above 20 milligrams, there was no improvement, but there was much more toxicity. In that case, they used weight gain. So if you looked at the forced vital capacity in patients treated with corticosteroids, 20 milligrams was the maximum dose that showed any improvement. Beyond that, these are absolute doses. So I think that for many aspects of sarcoidosis, 20 milligrams was probably an adequate starting dose. But we were not able to make a grade recommendation, nor in the committee were we able to make enough of a consensus to make a comment. So that's why this is left as your individual preferences.
Okay, just to follow up with the patient, she's in, I saw her recently a couple of days ago, she's in stable remission now without any use of glucocorticoids with methotrexate alone, so she's doing fairly well now.
Good.
Another point interesting is the delay with highest dose. And as shown by our friends from the Netherlands, it was shown that after 1 month, often we have a complete response, so we can decrease the dose at 1 month. And we observe the same thing for renal sarcoidosis. The response is obtained at 1 month, and we can decrease the treatment at 1 month, so we can decrease the total corticosteroid dose of the patient.
I think that's an important point, the question on when to taper down. If you need to use it for 4 weeks, 8 weeks, 12 weeks, and then taper down, or when to start tapering. Well, but you've nicely answered that issue as well. So, okay, I'm going to go to the last case I wanted to present. It's a 54-year-old female patient. She presented to a different hospital and actually to the neurology department in December of 2015 with headache, double vision, cerebral ataxia, and on the lumbar puncture, she showed pleocytosis, and the MRI of the brain showed meningitis. She was treated with prednisone at a different hospital. She improved slightly with those symptoms, but then in a couple of months later, she had progressive symptoms with tetraparesis and paresis of the abducens nerve. And the question now is, which steroid-sparing agent would you start at this point in time? And you have infliximab, mycophenolate, azathioprine, methotrexate, or intravenous immunoglobulins as options here, because the patient had already been treated with glucocorticoids, which we agree is first-line treatment for neurosarcoid. And please cast your vote. A couple of steps to make a choice. Okay, and 46% of all attendees chose methotrexate as the first-line treatment. Dominique and Bob, how would you treat a patient at this point?
I think I would have prescribed methotrexate first.
This is difficult. In the US, I couldn't get the patient infliximab until I gave them infliximab to methotrexate. But my preference would actually be to give this patient infliximab because they're progressing badly. And what I do in practice to get around my insurance companies is I give them methotrexate and have them come back 2 weeks later and say they failed methotrexate and start them on infliximab, because infliximab is going to work quickly. Often it will work within 2 to 4 weeks, and you really want to start decompressing that nerve that's being pressed. So although the algorithm has methotrexate and then goes to infliximab, I think that somebody who has this worsening progressive disease and you have a fear that you're never going to recover the leg movement, that you would go to infliximab sooner rather than later.
Okay, I'm going to let you know what, well, I pose here methotrexate as the first choice based on our recommendations, but I agree that infliximab has a strong role in neurosarcoidosis now due to relatively little toxicity. And but this patient, she was treated with azathioprine a couple of years back, you see 2016. No great recommendations were made by the panel, by the task force. So, and then she had slowly progressive disease. And when she came to my attention, she was unable to walk, and she had already been switched to mycophenolate, actually, over methotrexate, which was interesting. And she improved only slightly. And when I saw her, she was using a wheelchair, not able to walk, and she had gained a lot of weight because she had received a couple of prednisone pulses, methylprednisone pulses intravenously, which seemed to help, but she had developed secondary fibromyalgia. And she's still mobile as of February 2020. So the next question would be, which therapy would you choose now, infliximab or cyclophosphamide? So 90% of you would choose infliximab, and we did this as well, and she's doing fairly well now. I saw her actually this morning for her infliximab infusion, and she's able to walk again and kind of leading an independent life, and was able to taper down steroids. She's not asymptomatic. She has chronic disease, double vision, still headache, but she's able to walk actually with the infliximab infusion, and she's tolerating the treatment fairly well. So thank you. These were the cases I wanted to present you, and now I think we have time to discuss a couple of those questions that were addressed in the chat.
Yes, there are many very interesting questions. I fear that we will not have sufficient time. The first one, perhaps for Bob. What is a major pulmonary involvement? How do you recognize a major pulmonary involvement?
Well, as I said, this is all in the eyes of the beholder in some ways. We do have markers now that if they have fibrosis and they do have, that you want to try to get those patients. And we know that those patients with pulmonary fibrosis, about 70 or 80% of the time will still have a positive PET scan. And a study published by your group, Dominic, showed that these patients, at least a third of them will get better even if they look like they have end-stage honeycomb. And so patients with extensive lung disease, that's a major impairment. I think patients with, there was a question about ground glass, and that would be something that I would consider. I think also it's important that their vital capacity is below 70% or their DLCO is below 60%. These are also markers that we think of in looking for reversibility.
Mm-hmm. Thank you, Bob. There are 3 questions about inhaled corticosteroids. Do you use them?
I think that inhaled corticosteroids may be useful for cough. We did a double-blind placebo-controlled trial of this in the past, but that's about it. I would actually want to know the European experience, Dominic, is that because we can't get high-dose budesonide, which seems to be a little bit more effective than the dosage we can get in the U.S.
Mm-hmm. There is another question on treating patients with an obstructive syndrome. I think if FEV1 is very low, inhaled corticosteroids will not be sufficiently efficient. So we have to use a systemic treatment. There are many questions for corticosteroids on the duration of the treatment, on initial doses, but we discussed about that, and also about the treatment of relapses. Do we use steroids again?
Well, I'll start with that one, but actually I'd like to, my approach is to tell patients, once we start steroids, you're going to be on for at least a year or two. Not necessarily the same treatment and that's the same dose, but it's very unlikely that I can stop treatment within the first year. Once we've made that decision, crossed that Rubicon, made that decision. And so that may be immunosuppressives, switching over from steroids or may not be. As far as what happens when they relapse, usually depends on what they get relapsed from. If they were on methotrexate, we stopped it and they get relapsed and I put them back on methotrexate. If they're being tapered off steroids, they relapse, I up the prednisone, and then following the algorithm, then I would add the next drug, whether that be a cytotoxic or whether that would be something like infliximab.
There was also a question about azathioprine. Is there still any room for azathioprine? I can try to answer this question. There is a recent study from Sweden which confirms that infections are more frequent with azathioprine than with methotrexate. The benefit is probably very near, but probably there are more adverse events, particularly infections with azathioprine. What is your opinion?
Well, I agree. When we originally looked at starting these types of drugs, we started with methotrexate because we were afraid of the infections, the malignancy issue with azathioprine. The ophthalmologists have seen the same thing. And then there's the Jan Gruder's group that showed, compared to WIMWIT, that they had a higher rate of infection on those on azathioprine. Peter, what do the rheumatologists think about azathioprine now?
Well, azathioprine, we use it for a lot of conditions, especially connective tissue diseases like lupus or other myositis. And it's pretty well tolerated and usually effective in those conditions, and similar toxicity for lab tests like blood counts and liver function tests compared to methotrexate. But I see a couple of patients who early on develop toxicity secondary to azathioprine, like liver function test elevation and leukocytopenia, which is more frequent with azathioprine than with methotrexate, in my opinion. But patients who develop severe nausea, vomiting with methotrexate, they fairly well tolerate azathioprine.
Another indication is perhaps when you have patients with uncertain contraceptions, because it's less dangerous azathioprine than methotrexate for childbearing or even for males, I think. So when I am not sure at all, I prefer to propose azathioprine.
I mean, again, it's from the transplant literature that other than smaller babies in a higher spontaneous growth, they don't have the malformations that you see with methotrexate.
Yes, okay.
Yeah, for males, I think there are some safety data, at least from the rheumatology world, that methotrexate is safe in males if they want to have children still. So the toxicity is for women or for the children is fairly low, but for women having to be treated, azathioprine would be preferable. Absolutely.
There are a question for Peter, perhaps different persons other questions. What about the bone? What about the eye, etc.? Why we did not develop about these organs?
First of all, a bone and articular sarcoidosis are not as common as pulmonary, skin, and lymph node, but we have a couple of patients with exclusive bone sarcoidosis with granulomas on the biopsy, but you can tell really based on the imaging, MRI or PET scan, if it's secondary to sarcoidosis, which because it looks like metastatic disease, so you probably need a biopsy for bone sarcoidosis. And was the question related to treatment or to diagnosis? Diagnosis?
Mm-hmm. Okay, it was about both diagnosis and treatment. So
treatment is difficult to answer because there are no prospective studies on that. I would I would take the usual approach with glucocorticoids first and then add some steroid-sparing agent if they need to, and depending on the symptoms.
We published a series of over 60 patients treated for bone disease at our place. And about half of them actually don't have any symptoms that need therapy. And so, like we're talking about these other treatments, I think the general algorithm that we proposed, but we tend to try to quickly get off steroids. In our series, patients did better with cytotoxics and infliximab because of the osteoporosis of long-term steroid use. So if they're symptomatic, we try to get away from prednisone as quickly as we can.
And a question for both, do you how treat hypercalciuria?
Pardon? Which
how
one?
Treat increased calciuria?
Calciuria, calcium.
Yes, calcium in urine.
Yeah. So increased calcium in the urine, I always look for. The first thing you do is make sure they're not taking any vitamin D. The second thing you do is you check their vitamin D 125 or calcitriol level, because that's usually the problem in sarcoidosis, that they have too much of that. About 10% will have hyperparathyroidism. And then as far as treatment goes, if you have that problem of high 125, high calcitriol, then you treat with anti-inflammatories. Usually plaquenil hydroxychloroquine is your first choice, and then going down the other ones.
A question about antifibrotics in lung disease. I have a conflict of interest. I cannot answer this question.
I have a some conflict because we just finished our trial of pirfenidone that we presented at the ATS, where it was a small study. We're not able to show much difference between that and placebo. The nintedanib data showed that there was perhaps a benefit for, again, a small number of patients with sarcoid. I think that the jury is still out where antifibrotics, but it is something that needs to be further studied for those patients who have progressive fibrosis.
A very interesting question about our opinion on the use of corticosteroid in obesity.
In which one?
In patients with obesity.
Obesity, oh.
Yes, taper down quickly and add cytotoxic drugs upfront. Also in patients, older patients with diabetes, hypertension, which can really worsen with glucocorticoids, it's reasonable to add a methotrexate or some other cytotoxic drug upfront.
I think this is an important question because, point of fact, the patients, it's not uncommon for them to gain 20 to 30 pounds or more. In one of our trials, the average weight gain was 40 pounds, and that's part of the reason why you want to start at lower doses and move on. So, but I think it should be an absolute contraindication, because we really, unfortunately, the other drugs like methotrexate just take too long to kick in. So a patient who's symptomatic, start with steroids, but you may want to add that cytotoxic agent much sooner.
And another question for Bob. On methotrexate, how often you monitor liver tests?
All right, well, Peter can give his side from the rheumatology. What we do is we do it every 3 months, but we use a lower dose. We use 10 milligrams a week, 10 milligrams once a week, so we don't use as high, because we did see a lot more problem with leukopenia. If we follow our regimen, we published a paper, a large number of patients, followed over 600 patients on methotrexate for sarcoid. If you do it every 3 months, you don't really usually run into problems.
A question, can you give just methotrexate on its own? I do.
Then,
Yes,
you-
I do
you-
it sometimes when you have severe contraindications for steroids, and often it works well, but we lack studies, but I think there is an ongoing study in the Netherlands to evaluate the methotrexate versus corticosteroid as a first treatment.
Yeah, it just takes longer for the methotrexate to take its effect, like 8 to 12 weeks. You have to wait and educate the patient.
Yes.
But you can, of course, start without steroids.
Well, as I
Depends on the.
you mentioned people with eye disease will just go with topical steroids and start methotrexate. Cardiac disease, your case, if they hadn't had an ejection fraction of less than 40%, I would have probably treated with just methotrexate alone for the arrhythmias, because you've got the defibrillator in, and antiarrhythmics, they may not have a problem. You may be able to get away with waiting for methotrexate. So I think it's an individual decision.
Another question, interesting, how to differentiate sarcoidosis lung progression from methotrexate-induced lung disease. I think it's exceptional. I have only seen one case with a methotrexate-induced lung-induced disease with sarcoidosis among several hundred patients with methotrexate. I don't know your experience, but it's very, 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 very rare. And I think it's easy to differentiate because often methotrexate lung disease is very acute. The presentation is quite different on imaging than sarcoidosis. I think it's not difficult to make the difference. Your opinion?
Yes, you have to differentiate between acute pneumonitis secondary to methotrexate, which is, as you say, an acute illness. Patients are severely ill and often require admission to the ICU, and chronic progressive pulmonary fibrosis. We have a lot of data now from cohort studies in rheumatoid arthritis-related lung disease that they actually do better with methotrexate and develop less ILD secondary to rheumatoid arthritis. So I think progressive pulmonary disease with methotrexate is an exception, as you said.
Yeah, this is something that we obviously have looked at over the many years since we started methotrexate. Cough is usually the first symptom I see of methotrexate. And it's only a few patients that have an unexplained cough that really doesn't seem to make any sense. And that would heighten my awareness. It used to be a much bigger problem for me because I had no other alternatives, but with azathioprine, leflunomide, and mycophenolate, if there's any question in my mind, I'll just switch to another immunosuppressive. And usually if it's from the methotrexate, the cough goes away. But as Dominic says, this is pretty rare. And I've only actually had one patient who had biopsy confirmed methotrexate pneumonitis, and the rest of them had all been probably their sarcoid.
Sorry to interrupt. We have to close this session. These questions can be posted to you, and then you may choose to answer them in written and give them back to me, or record, your answer with the mobile phone or something and send me the file. I can post anything, on the website.
Bob, do you want to conclude? Do you want to conclude our webinar?
I just want to conclude that I want to thank again Dominic for co-chairing this task force. He had to work with my peculiarities and being 6 hours time zone difference and such. And I think the whole task force was quite work. Can't overemphasize the help of the methodologists, especially Peter, in helping us make the algorithms. And I hope you'll find them useful.
Thank you. And thank you, Bob. And thank you, Peter. And
Thank
all
you.
others.
Thank you very much. Excellent session.
Thank you, and thank you. And thank you, Ali, for your help. You were very helpful.
You're welcome. Thank you, Dominic. Bye-bye.
Goodbye.
Thank you very much. Have a good evening.
Bye.
Bye.
Evening.